Welcome back to this next video in which we are discussing kidney disease. So in this next video, what I'd like to talk about is the different causes of CKD, chronic kidney disease. And we'll see that by doing this, we'll also end up discussing different causes of renal hypoperfusion, that final category of presentation of kidney disease that I talked about in the first video. And the reason for this is that many of the diseases that we're going to discuss as causes of chronic kidney disease, they can initially give rise to a long period of renal hypoperfusion where the presentation is that of renal hypoperfusion before they then progress into the CKD picture. And that will hopefully make more sense once we've actually discussed some concrete examples. So, let's then begin with the causes of CKD. So how do we categorize the causes of CKD? Well, we do it the same way as we categorize the causes for AKI. We split it into pre-renal causes, intrarenal causes, and post-renal causes. So pre, intra, and post, where again, pre means anything prior to the nephrons, intra means a problem with the actual nephrons themselves, and post means a problem with the urinary tract downstream of the nephrons. So let's begin then with pre-renal causes. So there is one major disease that I want to discuss here, and this is renal artery stenosis, that we will abbreviate down to RAS, not to be confused with the renin-angiotensin-aldosterone system that is sometimes just called the renin-angiotensin system and therefore is abbreviated also to RAS. So, renal arteries then. You have two renal arteries, a left one and a right one. The left one supplies the left kidney and the right one supplies the right kidney. And stenosis means narrowing of a tube. So renal artery stenosis means narrowing of the renal arteries. Now this can happen, and we'll discuss why it happens in a moment, and this can lead to CKD, and indeed it's a pre-renal cause because it is prior to the nephrons. So let's discuss what can cause renal artery stenosis, and then we'll discuss what effect it can have on the kidneys. So there are two major causes of renal artery stenosis, and you can probably easily name one of these, and the other one you might have more difficulty naming. So one of them is atherosclerosis, that I will abbreviate down to AS for short. So atherosclerosis is a major problem, a major disease of the cardiovascular system, and it causes, well, it is the development of atherosclerotic plaques in the tunica intima layer of arterial walls, and it results in the narrowing of those arterial lumens. Now, it can occur in arteries all over the body. Classically, the places that it occurs is the coronary arteries, the carotid arteries, and the cerebral arteries, leading to massive problems with the perfusion of the heart and the perfusion of the brain. However, it can also occur in the renal arteries. It's much rarer for it to occur in the renal arteries, but it can occur there, and when it does, it can lead to renal artery stenosis. And by the way, when renal artery stenosis occurs, usually it occurs bilaterally, so it would be very unusual to get unilateral renal artery stenosis. Usually, when we say renal artery stenosis, we're referring to bilateral renal artery stenosis. So atherosclerosis is one of the causes for renal artery stenosis. The other one that you might have more difficulty naming is a disease called fibromuscular dysplasia. Now, this is something that we do not really understand that well, and again, it can occur in loads of different arteries all over the body. Now, look at the name, fibromuscular, whoops, missed out a letter, dysplasia. Fibromuscular refers to connective tissue and muscle, which of course is what the arterial walls consist of. They consist of connective tissue and a muscle layer, the tunica media. Dysplasia refers to a problem with the division of the cells in those layers. And what happens in fibromuscular dysplasia is literally the wall of the artery becomes far too thick, the muscle layer becomes too thick, the connective tissue layers become too thick, and the lumen of that arterial vessel becomes smaller. This can occur in the renal arteries, and when it does, it leads to renal artery stenosis. Now, in contrast to atherosclerosis that generally occurs in older people, and risk factors are things like having high blood pressure that also generally occurs as we get older. Smoking is another risk factor. Having too high cholesterol level, in particular LDL cholesterol within the bloodstream, is another big risk factor. In contrast, fibromuscular dysplasia generally occurs in young women. So it's a very, very different disease to atherosclerosis, one that we do not properly understand yet, but it can occur in the renal arteries and it can lead to renal artery stenosis. So these are the two major causes for renal artery stenosis. And again, I'll stress that these are rare arteries to be affected by stenotic phenomena. So renal artery stenosis is thankfully quite a rare phenomenon, but it can occur. Now, what is this going to lead to? Well, you may well be thinking now, if you get stenosis of the renal arteries, what's going to happen? The amount of blood getting to the kidneys is going to gradually get lower and lower and lower. And by the way, these are chronic processes. This does not happen overnight. This is going to develop over years and years. The renal arteries are going to gradually get narrower and narrower, and renal perfusion is going to get lower and lower. So gradually, in the initial phases where it's not too bad, what's it going to do? You're going to get renal hypoperfusion, but it's not going to be bad enough to actually cause CKD. The nephrons are going to be fine, they're not going to start dying yet and being replaced by scar tissue. Instead, what you're going to get is the phenomenon of renal hypoperfusion. So this is where I said many of these diseases are going to initially present as renal hypoperfusion and then develop into CKD. So initially, it's going to be renal hypoperfusion, so you're going to get overactivation of the renin-angiotensin-aldosterone system and secondary hypertension. Then, as the disease progresses over years and years and years, the stenosis is going to get worse and worse potentially. Then you're going to actually start getting nephron loss, and permanent nephron loss, and replacement by scar tissue, and at that point you're going to start presenting as CKD. And by the way, the renal hypoperfusion syndrome is going to go as the CKD comes in, the reason being that in order for the renin-angiotensin-aldosterone system to be active, you need to have your full complement of nephrons. Remember, the initial part of the renin-angiotensin-aldosterone system is renin. Renin is released by nephrons. If you're losing nephrons, then you're going to be losing those contributors to the renin-angiotensin-aldosterone system. So gradually, as you develop CKD, loss of nephrons, you're going to lose the starting point for the renin-angiotensin-aldosterone system. Renin will go down gradually, and you'll actually end up with renin-angiotensin-aldosterone system underactivity as CKD progresses. So don't think that these two are going to, in the end, be side by side. No, as this one occurs, the renin-angiotensin-aldosterone system is going to start failing. So this one's going to end, basically. Right. So that's the major pre-renal cause of chronic kidney disease, and as we've seen, it begins by causing this renal hypoperfusion syndrome and then progresses into a CKD picture. Let's now talk about intrarenal causes, and this is really, really important. So, we have seen a lot of very rare diseases in this video on kidney disease, and when we were talking about AKI, the most important causes of AKI for you to know are the pre-renal causes that we discussed, dehydration and sepsis-induced AKI, and the post-renal causes. Those are far more common than the intrarenal causes. Of the intrarenal causes, the most important one for you to know about was the tubular necrosis. When we come to CKD, again, we're going to discuss some rare diseases. Renal artery stenosis is a rare disease. We've already discussed a rare one. The two most important ones are about to come up now, and I'm going to write them down together because they are the two most important causes of CKD. If you see someone with CKD, you should think it is due to one of these two until proven otherwise, okay? And these are diabetic nephropathy and hypertensive nephropathy, HN. So diabetic nephropathy is disease of the kidneys, chronic kidney disease caused by diabetes, and it's caused by the hyperglycemia that occurs within diabetes. Hypertensive nephropathy is a result of long-term hypertension usually essential hypertension, because that's far more common than secondary hypertension, and it's a disease of the kidneys that results from long-term too high blood pressure. Of course, what you may notice is we've discussed how several diseases that we're going to discuss several diseases that lead to renal hypoperfusion, and indeed this one actually does lead to renal hypoperfusion itself. And we know then that that leads to secondary hypertension, so it's going to make the hypertension worse. So actually a vicious cycle is going to form, and I'll talk about that in a bit more detail when we come on to hypertensive nephropathy. So again, let me just stress this point. Of all the causes of CKD that we are about to discuss, these are the two that you should learn above all others. They are the most common causes of chronic kidney disease in the population, because diabetes and essential hypertension, those two components of the metabolic syndrome, are so common. Right, so let's talk about diabetic nephropathy first. What happens? So there's another name for diabetic nephropathy. You can also call it diabetic glomerulosclerosis. And we've seen this word before when we discussed focal segmental glomerulosclerosis. Glomerulosclerosis means hardening of the glomerular basement membrane. It means more connective tissue being laid down in the glomerular basement membrane and the thickening of the glomerular basement membrane. Now, whereas focal segmental glomerulosclerosis could actually be quite an acute presentation, diabetic nephropathy or diabetic glomerulosclerosis is going to occur over a long period of time. So long-term hyperglycemia can lead to glomerulosclerosis occurring in the glomeruli all over your two kidneys. And what this will gradually lead to is a reduction in glomerular filtration, because if that glomerular basement membrane becomes thicker, less is going to get through it, less is going to be filtered. So gradually all of your nephrons are going to become less efficient, and some nephrons may even start to be lost and replaced by scar tissue. So this is what's going to happen in diabetic nephropathy. You're gradually going to get the deteriorating function of all your nephrons, and as a nephron's function goes down and down and down, what will gradually happen is it will be destroyed and replaced by connective tissue. If it's not functioning, what often the body ends up doing is getting rid of it. Lose it or lose it is a philosophy that the body seems to apply all over the place. So this is what can happen in diabetes, and that's why it's so important to control blood glucose level in people with diabetes. Now, unlike hypertensive nephropathy, diabetic nephropathy doesn't really give rise to this period of renal hypoperfusion. It just gradually causes CKD. And this is why we are so fussed about controlling the blood glucose level of people with diabetes, because of the effect that it can have on the kidneys. Next, hypertensive nephropathy. So hypertensive nephropathy causes a phenomenon called nephrosclerosis. So another name for hypertensive nephropathy is hypertensive nephrosclerosis. So what does that mean? So nephrosclerosis is similar to glomerulosclerosis, however it's broader. It means thickening of the basement membrane of the glomeruli, but also the arterioles as well. So you get thickening of the basement membrane of the afferent and efferent arteriole as well. So let me just again draw a picture of our glomerulus and our Bowman's capsule, the renal corpuscle. So here is our Bowman's capsule and the renal tubule. And then remember we have a afferent arteriole here and an efferent arteriole here, and then we have our glomerulus in between. Now, in glomerulosclerosis, the glomerular basement membrane gets thicker. That's what's going to happen when you're exposed to long-term hyperglycemia in diabetes, diabetic glomerulosclerosis. When you're exposed to long-term high blood pressure, what happens is the basement membrane of the afferent arteriole and the efferent arteriole and the glomerular basement membrane, all of these get thicker. Now, can I just say that the actual pathogenesis of these phenomena, diabetic glomerulosclerosis and hypertensive nephrosclerosis, is an ongoing area of research. What's actually happening to cause the thickening of these connective tissue membranes is not well understood, but you can probably understand when you've got very high blood pressure, you can understand why that's going to put strain on these blood vessels that might lead to division of connective tissue cells and them spewing out more connective tissue to try and strengthen the walls of the blood vessels. It's more difficult to understand why elevated blood glucose is going to lead to glomerular sclerosis, but that's an area of ongoing research. Right, so it remains a fact, however, that what happens in the renal corpuscles of the kidneys of people with long-term hypertension is that the basement membrane of the afferent and efferent arterioles, as well as the actual glomerular capillaries, is going to get thicker and thicker and thicker. Now, this is interesting. This is more interesting than diabetic nephropathy, because when the basement membrane gets thicker, these afferent arterioles and indeed the efferent arterioles, but in particular importance is the afferent arteriole, that's going to get narrower because the basement membranes become thicker and it's compressing all of the inner tissue and therefore compressing the lumen of that vessel. And what that is going to do is it's going to reduce perfusion through the glomerulus, i.e. it effectively reduces renal perfusion. So again, it is going to give rise to the renal hypoperfusion phenomenon. So this too is going to start by giving rise to renal hypoperfusion, but that's really bad because that's going to activate the renin-angiotensin-aldosterone system and it's going to elevate blood pressure even more. So you form a vicious cycle of the damage that the high blood pressure is doing to the kidneys, causing further damage to blood pressure, raising blood pressure even further, which will then cause further damage to the kidneys, and it just keeps going on and on like that. Gradually, it's then going to lead to the CKD picture, so this is going to then progress to CKD. And the reason it will progress to CKD is, one, the blood flow to this nephron is going to get smaller and smaller and smaller gradually, and that may lead to the loss of nephrons. And two, the same reason as what we saw in the diabetic nephropathy case, nephrosclerosis includes glomerulosclerosis, so getting thickening of this basement membrane that is going to reduce the glomerular filtrate rate of all the nephrons all over the kidneys, and is therefore going to gradually lead to a chronic loss of kidney function. And when nephron glomerular filtrate rate gets to a certain low level for a long period of time, it may well lead to the complete loss of those nephrons. So gradually, hypertensive nephropathy is going to lead to all the nephrons becoming less functional, even the loss of nephrons, a CKD picture, and of course then you'll get renin-angiotensin-aldosterone system failure, and that actually might help your hypertension finally, but of course it's far too late for your kidneys at that point. So these are really important to know about diabetic nephropathy and hypertensive nephropathy. And again, I'm going to stress this point. If you've got an individual who you know has got CKD, the likely reality is that it's caused by either diabetic nephropathy if they're diabetic. If not, check their blood pressure because that will probably be high. And that in that case, it's hypertensive nephropathy. Until proven otherwise, it should be your conclusion that CKD is caused by diabetes or high blood pressure. And this is the reason that we take these diseases so seriously, why we want to lower people's blood pressure who have essential hypertension so much. Right, so there we go. There is hypertensive nephropathy. We're now going to go back to rare diseases. We're going to leave the commoner diseases and we're going to talk about a final cause of intrarenal, or a final new cause for intrarenal kidney disease, which is polycystic kidney disease, PKD for short. So this is a rare genetic condition, and it's spelt like so, polycystic kidney disease. So again, I'll stress this is very, very rare. So, polycystic kidney disease. There are two different forms of polycystic kidney disease, childhood polycystic kidney disease and adult polycystic kidney disease. Adult polycystic kidney disease, the formal name for it is autosomal dominant polycystic kidney disease. These are genetic conditions. Childhood polycystic kidney disease, the formal name for it is autosomal recessive polycystic kidney disease, AR-PKD. So, the A of course, refers to autosomal, and autosomal means that the gene that is responsible for the disease is present on one of the autosome chromosomes, so not the sex chromosomes, any of the other 22 chromosomes that isn't a sex chromosome. So both forms of polycystic kidney disease, the adult form up here and the childhood form down here, both of them are autosomal. Dominant means that you only have to have one copy of the disease allele to get the disease, whereas recessive means that you have to have both copies of the disease allele in order to get the disease. Now, the reason it's called polycystic kidney disease is that in both diseases you're going to get cysts forming within the kidneys. Let me just explain this a little bit more. So let me just draw a picture of a nephron here. So again, a very basic picture. So here is the loop of Henle and the distal convoluted tubule and then the collecting duct, like so. What happens in polycystic kidney disease is that cysts, which are fluid-filled sacs, develop from nephrons. So what can happen on the side of a nephron if you've got polycystic kidney disease is a great big sac can form off the side that is lined by renal tubule cells, and this is a cyst, and these can get absolutely enormous, these great big cysts. Now, these diseases both gradually lead to chronic kidney disease, both the autosomal dominant and the autosomal recessive form. They're going to lead to chronic kidney disease and eventually complete renal failure in many people. The reason we call one adult and one childhood is unfortunately they're different severities, and the childhood form is greater severity. This one is worse and progresses to CKD more quickly, and therefore often people with autosomal recessive polycystic kidney disease do not make it to adulthood, which is why it's called childhood polycystic kidney disease. Some of them will make it to adulthood. It's becoming more common now with the miracles of modern medicine, but it's less likely. It's a more severe form of the disease. This one, you're much more likely to make it to adulthood and a good age usually. So it's called adult polycystic kidney disease for that reason. So let's just talk about the genes a little bit more. So autosomal dominant adult polycystic kidney disease, there are two genes that are known to cause this disease. One is polycystic kidney disease 1 and the other is polycystic kidney disease 2. And both of these genes have alleles that will confer this disease. And if you have one of those disease alleles, you only need one of them on one of your two homologous chromosomes in order for you to then get the disease. So to make this utterly plain, in order for an individual to get polycystic kidney disease, adult polycystic kidney disease, they need to have a disease allele in one of these two genes. You don't need to have a disease allele in both of them, you just need a disease allele in one of them. So if you had one of your PKD1 genes a disease allele and one of them normal, and both of your PKD2 genes normal, that will give you adult polycystic kidney disease. Alternatively, let's say both your PKD1 genes are normal, but one of your PKD2 genes is a disease allele, then that will give you adult polycystic kidney disease. So it's autosomal dominant. These genes are on the autosomes and you only need one copy of the disease allele in order to get this disease. And the disease involves these cysts forming from the renal tubules that can get extremely large and fill up with fluid. Autosomal recessive, the disease is known as the gene is known as PKHD1. And this stands for polycystic kidney and hepatic disease 1, because these diseases actually can also lead to cysts forming inside the liver as well. Both of these forms of polycystic kidney disease can lead to liver cysts forming. It's more likely in the more severe form than in the less severe form. That's why this gene is called that, because you can also get hepatic cysts. Hepatic cysts are much rarer to form than the renal cysts, so the kidney disease is the bigger problem than the hepatic disease in these diseases. So let's summarise what I've said so far about polycystic kidney disease and put it all together into what's actually going to happen to these individuals. So two different forms of polycystic kidney disease: adult or autosomal dominant polycystic kidney disease and childhood autosomal recessive polycystic kidney disease. They differ in severity. This one is more severe than this one. What actually happens inside the kidneys is that gradually these cysts are going to form on the side of your nephrons within your kidneys, and your kidneys are therefore going to end up with a huge number of cysts inside them. And these cysts don't all form over at once. They are going to form over years usually. So you're going to get gradually more and more cysts forming inside your kidneys, and they're forming on the sides of the nephrons. So let's now actually put this together and think about what this is actually going to do to your kidney function and what symptoms it's going to give rise to. So this actually is another disease, that usually is going to initially give rise to a presentation consistent with renal hypoperfusion, and it's then going to progress to CKD. And let me explain why. So as more and more cysts form within your kidneys, the cysts are not problematic for the nephron. The nephron can continue functioning despite the cyst being here. The problem is that the more cysts that form in the kidneys, the higher the pressure is going to be inside the kidneys. And the more pressure increases inside the kidneys, the less blood is going to be pushed through the kidneys. Because you can imagine, if the kidneys are a very high pressure structure, it's very difficult for blood to be pushed into and through the kidneys. So renal perfusion is going to go down initially as the pressure within the kidneys builds up. So that initially gives rise to this renal hypoperfusion picture, where an individual develops secondary hypertension because of renin-angiotensin-aldosterone system overactivation. Gradually, what is going to happen is the cysts are going to burst and trigger massive inflammation and destruction of nephrons inside the kidney. So you are going to gradually lose your nephrons from inside the kidneys as the cysts destroy the normal tissue. And as that occurs, you'll get this CKD picture taking over with renin-angiotensin-aldosterone system failure, and therefore the secondary hypertension will abate. So it'll move from this picture to this picture. So this is the picture where you haven't significantly lost healthy nephrons, but the pressure is building up and up and up inside the kidneys, so you're getting renal hypoperfusion. Once you actually do start losing functional nephrons, then it's going to progress to CKD. So there we go. There is a brief discussion of polycystic kidney disease, an autosomal disease of the kidney, very, very rare, thankfully, but a very serious disease. The other thing to be aware of with polycystic kidney disease is that the cysts can bleed, so this can give rise to hematuria, because of course the cyst is connected to the nephron. So if the cyst is bleeding, so if blood is going into the cyst here, it will then be able to drain into the actual lumen of this nephron and then end up in the urine. So another symptom of polycystic kidney disease is hematuria, and that can be occurring even whilst you're in the renal hypoperfusion presentation of the disease. So you can end up with secondary hypertension and chronic hematuria as your initial presentation for polycystic kidney disease, which will then progress into CKD with hematuria. Right, and there we go. Those are the major intrarenal causes of CKD that we have not already discussed. All of those horrible intrarenal diseases that can cause acute kidney injury, we need to add them on here, because chronic versions of them, so chronic glomerulonephritis, chronic interstitial nephritis, and chronic tubular necrosis, all of these can damage the kidneys so badly that you'll permanently lose nephrons and therefore can give rise to a CKD picture. But of course we discussed that at the time that we were going through those diseases when we were discussing them for AKI. So I'm not going to re-discuss them here. So there we go, that's intrarenal causes of CKD. The final thing we just need to say is post-renal causes. And this again, we've already done the hard work because it's the same as for acute kidney injury. So we discussed in acute kidney injury how hydronephrosis can lead to acute renal failure, because quite simply the nephrons cannot move fluid through them if there's nowhere for it to go once the nephron ends. If you get chronic hydronephrosis, the high pressure in the renal pelvis and all of that fluid backing up the renal tubules can lead to destruction of those renal tubules and therefore permanent loss of the nephrons and replacement with scar tissue. So chronic hydronephrosis can cause post-renal CKD. And that's it. Those are the causes of CKD. Thank you very much for watching this video. We will end it here. I hope that it has cleared up your ideas of different causes of renal disease and given you a way of categorizing it and organizing it in your mind. Just before we do end, let me say that final presentation that we had of renal hypoperfusion, here are the sort of diseases that can give rise to that. Renal artery stenosis can give rise to a renal hypoperfusion picture. Hypertensive nephropathy or hypertensive nephrosclerosis can initially give rise to the renal hypoperfusion picture, and also polycystic kidney disease can also give rise to initially that renal hypoperfusion category of kidney disease. So that's why I put it there as a separate category of presentation for kidney disease. And you can see now that it is the one that often precedes CKD in these diseases. They initially give rise to a period that may last many years of that picture before you then get enough nephrons being lost that it develops into a CKD picture. So, thank you for watching this video.